So I don't need to remind this audience about the magnitude and the burden of cardiac arrest, which is a major public health problem. In the United States alone, we're talking about close to 500,000, 500,000 individuals who are affected each year. And it's important also to remember that between 50 and 70% of cardiac arrest victims will have long-lasting neurological sequelae. Perhaps the most dramatic sequelae that are seen, in particular in cardiac arrest victims, but also in patients with other severe brain injuries, are these long-term disorders of consciousness. And this is a very nice representation of these disorders of consciousness. If you think about the two dimensions of consciousness, the motor function, which is the behavioral phenotype that exhibits consciousness when we examine a patient, and if you think about the cognitive function or the awareness, which is represented here on the x-axis, you can see that if you move from, this is you and I up here, so we are fully cognitively intact and we have full motor function, I hope, all of us. And then down here we have the patients who are comatose, who have a complete or near complete loss of motor responses and who have significantly diminished cognitive function, who are unaware and who are, have no arousal. You can see that between these two extremes you have a variety of states of impaired consciousness, including the vegetative state, which is characterized by some elements of arousal but no awareness, and the minimally conscious state, which is characterized by intermittent but inconsistent elements of awareness. So the reason I'm showing you this slide is because these states of chronically impaired consciousness are extremely frequent after cardiac arrest. And the question is, are we able to better differentiate, using techniques such as MRI, which patients will evolve towards these states versus those who will have a better outcome? One of the pathophysiological explanations for this high incidence of vegetative state in patients after cardiac arrest is the differential vulnerability of the brainstem when compared to the cerebral cortex in the setting of global cerebral edema. We know, and this slide demonstrates it, that as you increase the time of global ischemia, the burden of damage is significantly higher in the hemispheres, in the cerebral cortex and the subcortical structures, than it is in the brainstem. And so this comparative preservation of brainstem is perhaps what explains, at least in part, the high incidence of these states, such as the vegetative state, where you have individuals who have preserved brainstem function but have no ability to relate to their environment. Remember that the pathophysiology of cardiac arrest is complex, involves multiple steps, multiple pathways. Some of the important ones, nevertheless, are, of course, ischemia, which almost always is related to some degree of cerebral edema, and this cerebral edema can be either interstitial or vasogenic in nature, or it can be cellular or cytotoxic. There is then the reperfusion, which in cardiac arrest can be quite complicated. It's not simply a question of restoration of blood flow. In many cases, it's believed that you can have a hyperemic response where the blood flow not only returns to normal but becomes supranormal after cardiac arrest. In many other instances, there has been this description of a perpetuation of the ischemia due perhaps to intravascular thrombosis. And so the reperfusion after cardiac arrest is something which is being intensely studied and which contributes significantly to the morbidity and mortality after cardiac arrest. And we also know that individuals after cardiac arrest have severely dysfunctional autoregulatory mechanisms, and this can also contribute to challenges in the management. So when we talk about imaging, I think it's helpful to think about neuroimaging within the broader context of brain mapping. And if we think about quantitative approaches to brain mapping, we can break this down into neuroimaging methods which tell us something about brain anatomy, so CT scan as discussed just now by Dr. Horn, MRI, which I'm going to talk about. And then there's also a multitude of methods to assess neural activation, and this can include EEG, as was discussed this morning by Dr. Vespa and Dr. Otto, evoked potentials, positron emission tomography, functional MRI, and then some of these more esoteric techniques which are really not used in the ICU, but which are having a profound impact in terms of how cognitive neurosciences are advancing. And I'm thinking in particular of MEG, which is magnetoencephalography, and transcranial stimulation using either magnetic or direct current. This is a slide which tells you something a little bit about the trade-off between temporal resolution and spatial resolution when we're thinking about these different brain mapping techniques. So you can see that, for example, if you use a technique such as patch clamp, cellular patch clamping, you have exquisitely good temporal resolution and exquisitely high spatial resolution. On the other extreme, when you're using techniques such as CT or MRI, you are losing significantly in temporal resolution and also in spatial resolution. And then in between here, you have, for example, EEG, which provides excellent temporal resolution but does not have such good spatial resolution. So when we talk about MRI in cardiac arrest, we can think about it in terms of three broad domains. There is the anatomical characterization that we can obtain, looking at lesion size, density, distribution. There is the metabolic assessment that we can do, looking at blood flow, looking for ischemia, looking at neurochemistry. And then there is the analysis of neural activation, which is accomplished principally using functional MRI. What can we do, though, in the clinical setting with MRI in patients with cardiac arrest? I think there's four basic things. We can diagnose injury. We can help to predict outcomes. We can evaluate the effect of treatments. And perhaps as well, and perhaps most importantly, we can understand some of the underlying mechanisms. This is a very recent study, very interesting, only 12 patients. And what the authors did was they performed MRI, volumetric MRI, in survivors of cardiac arrest. And this was done a median of 15 months after the insult. And what you can see is that there is quite significant amount of atrophy, and this atrophy is not diffused, it's not indiscriminate, it is actually region selective, and it seems to include certain specific areas such as the insula, the pulvinar of the thalamus, the hippocampal areas, and significant portions of the medial frontal lobes and parietal lobes, and also the insula, as I mentioned earlier. So there is this region-specific selectivity of the atrophy that seems to occur after cardiac arrest. When we think about cardiac arrest, when we talk about edema, MRI provides us with a methodology which is very sensitive to even very small amounts of brain edema, and this is the so-called diffusion weighted imaging. So diffusion weighted imaging tells us something about the probability of diffusion of water molecules, and by looking at that probability of diffusion, we can actually make inferences on the microarchitecture of the tissues in the brain. It's a very, very powerful technique. This is an old study going back to the mid-90s showing how in the presence of prolonged ischemia, you have a very rapid decay, rapid decline in this apparent diffusion coefficient, which is a measure of the amount of interstitial edema. So very rapidly reduced, meaning that the interstitial edema is down, the cellular edema is up. So in the setting of acute ischemia, you have, not surprisingly, cytotoxic edema which is occurring. If you look at the bottom part of the slide, you can see that in a cardiac arrest model, within 10 minutes, you have the ADC values which are declining precipitously, suggesting important amount of cellular edema. And here you have independent confirmation using another technique to measure extracellular space, and you can see that there is this rapid decline in the volume of extracellular space occurring in the setting of either focal or global ischemia. This is a very interesting study looking at the time course in an animal model of global cerebral ischemia, and you can see here that they measured the ADC value, they measured the cell membrane potential, and they measured extracellular concentrations of glutamate, which you remember is one of the principal excitotoxic mediator. And you can see that over time, after a simulation of global cerebral edema, you have a drop in ADC which seems to actually precede the drop in membrane potential and seems also to precede the rise in extracellular glutamate, suggesting that this ADC may be a very early marker actually of neuronal or of cellular injury in the brain in the setting of cardiac arrest. So in the clinical setting, when we look at the different sequences that we use in MRI, what is the usefulness, especially with respect to time, of these different sequences and the location? We can break down the period after cardiac arrest into these epochs for imaging. The first 14 days, what is most notable are diffusion-weighted hyperintensities involving the cortex, the basal ganglia, the thalamus, and the cerebellum. As we progress to the period of 2 to 3 weeks, you start seeing these abnormalities become apparent no longer just in diffusion-weighted imaging, but also with techniques such as FLAIR. And then beyond 21 days, what is perhaps most notable is that the abnormalities detected in the cortex and in the basal ganglia begin to go away, and what is most dramatic are diffusion-weighted abnormalities detectable in the white matter, the subcortical white matter. This is interesting, one of the first papers, sort of case series looking at diffusion-weighted imaging in cardiac arrest, published by my friend and colleague Julio Shalela. And what he noted is consistent with these observations, meaning that when he measured this mean ADC value in different parts of the brain in cardiac arrest victims less than 1 week after the insult, the lowest ADC values, meaning the highest preponderance of cytotoxic edema, was actually noted in the centrum semiovalle, which is a white matter structure. And this is the imaging correlate of what Julio found, and you can see extensive diffusion hyperintense lesions involving here the centrum semiovalle, here the corpus callosum, and here again in these subcortical white matter structures with the corresponding ADC map. So you can see here FLAIR, diffusion-weighted imaging, ADC map, and this is a T2 sequence. And these findings on MRI are consistent with neuropathological studies showing that in a significant proportion of cardiac arrest victims, the most severe damage is, interestingly, not in the gray matter, it is indeed in the white matter, and in the white matter that connects the different parts of the brain to each other. This is a paper by my colleague, Ona Wu, and what these investigators did, Dr. Wu and Dr. Greer, was they parcellated the brain using MRI into different gray and white matter structures, and they measured the ADC values within these different structures. So this atlas-based approach was used to help identify MRI as a predictor of 6-month outcome. And what they found was that ADC values were significantly lower in those individuals who had a poor 6-month outcome as measured using the Rankin scale. And this was particularly evident in the parietal lobe, the occipital lobe, and in the putamen. This is a very elegant study from Christine Wijman, where she looked at the evolution of MRI after cardiac arrest, and she analyzed outcomes by stratifying her patients into 3 different groups at 6 months. Those who were either dead or vegetative, those who were alive and had minimal or no disability, and those who were alive at 6 months but had significant disability or were vegetative. When she looked initially at just 1 week survival, what this group found was that there was a significant difference in total brain volume with ADC below this threshold of 650, and that the discrimination between those patients who did poorly and those who did well was particularly evident in this period of time, between 49 hours and 108 hours after cardiac arrest. And then here is the data looking at 6-month outcomes. And you can see that when comparing those individuals who are dead or vegetative versus those who are alive, you can see that there's a significant difference in the proportion of the brain that had a low ADC value, and the same was observed when they analyzed patients according to good and poor outcomes. This is a reanalysis of some of the same patients. 33 of these patients who underwent MRI less than 8 days after cardiac arrest. 6-month Glasgow outcome scale was analyzed. And you can see here, again, they found this region-specific selectivity for the low ADC values, most predominant in the occipital lobes, in the putamen, and in the hippocampus. So another development in terms of MRI technology is the use of diffusion tensor imaging, which tells us not only something about the ability or the probability of water molecules to diffuse in the brain, but also something about the directional preference of those water molecules. By analyzing the directional preference of the water molecules, we can also make inferences about the integrity of, for example, white matter tracts and whether or not they are damaged. So this, using diffusion tensor imaging, you can of course obtain these very nice images, these tractograms, and you can see here, for example, this is a control subject, different views of the brain. This is a subject after severe TBI, and you can see that there is diffuse loss of white matter, which also involves the brainstem. And here, in this individual after cardiac arrest, you can see also diffuse white matter loss. Interestingly, the brainstem was comparatively spared in this particular case as compared to this patient with TBI. And this is consistent with what I was telling you earlier about the comparative preservation of brainstem in cardiac arrest victims. This is data from my colleague Louis Pubassin in Paris, and this is data that has not yet been published, but he looked at the fractional anisotropy in 61 patients after cardiac arrest and compared those who had a good outcome and those who had a poor outcome at 1 year. And what he found was that consistently across all these different brain regions, the fractional anisotropy was significantly lower in those individuals who had a poor outcome. And when he performed a receiver operating characteristic analysis, what he found was that the DTI, actually this diffusion tensor imaging parameter, was probably the most predictive element, more predictive than, for example, the ADC values of the gray matter, more predictive than the clinical scoring system that he had also implemented in this small patient group. And to finish, I would like to just talk a little bit about functional MRI. And this is a very intriguing study where they performed the fMRI equivalent of somatosensory evoked potentials. And essentially what they did was they stimulated, for example, the right hand, and they recorded the bold signal over the left somatosensory cortex. And you can see that there is a correlation which occurs with both the Glasgow Coma Scale on admission and the Glasgow Outcome Scale, and the same was observed on the other side. So you can do these interesting games where you can perform, in a sense, the same test as you're obtaining with somatosensory evoked potentials, but you can do it using functional MRI. And to finish, just a couple of slides on the use of functional MRI to assess patients long time after cardiac arrest. And this is a paper from Martin Coleman in Cambridge, where they implemented a hierarchical language interpretation paradigm. So they started off with simple, the ability to differentiate between noise and no noise, between words and noise, between sentences and words, and between ambiguous and non-ambiguous sentences. And you can see that those individuals who are capable of the most complex language interpretation were the ones also who had the greatest likelihood of recovery, and this was done in a population that was composed almost essentially of cardiac arrest victims. This is also a very interesting paper from the group in Liège, Stephen Lories and company. You can see that when you analyze the bold signal in different parts of the brain, you can actually draw a map of that bold signal, and you can look at the temporal coherence of that signal as it occurs in different parts of the brain. By looking at that coherence, you can derive indices of connectivity. And what Stephen Lories and his colleagues found was that when you compared the connectivity in individuals who were, for example, comatose, it was significantly reduced when compared to, for example, minimally conscious patients or healthy controls, suggesting that this intrinsic functional connectivity may actually be a very important biomarker of patients who have impaired consciousness after severe brain injury. So to summarize, and I hope I'm within the time, the clinical examination and CT scan unfortunately do not accurately assess severity and prognosis of brain injury after cardiac arrest. We know that MRI is sensitive to the type of injury, to the anatomy, to the time course. Quantitative diffusion-based methods have prognostic significance. I think in cardiac arrest survivors with disorders of consciousness, we're going to see more and more studies using functional MRI, and I'm hoping that this methodology is going to finally enter into the clinic in terms of assessing brain function and also making predictions about outcome. Of course, we need many, many more studies, and some of these are ongoing within my group. to understand the relevance of MRI, both structural and functional, in predicting outcomes after cardiac arrest. So I will stop there.